Everyone for attending our sepsis nursing grand rounds for our Sepsis Awareness Month. And I want to introduce our presenters. So one of our key presenter is Jasmine Lyons. She's part of the quality management team. She's the sepsis coordinator, our lady in red. Ross Feynman, he's the senior manager for quality management. Raise your hand, Ross. And then we have our physician partner, Dr. Loftus. She's our hospitalist here, specifically on 4D. They love her. And of course, one of our prestigious nurses, Constantinos, Mav Romatis. Actually, just to give you a little context on Kaz, he was actually one of our ED techs, went back to school and got his nursing degree and started his first nursing job here into DSU, and now is participating in the PACU Fellowship. So these will be our key presenters on discussing our Sepsis Awareness Month. Thank you. And Jasmine will begin the presentation.
Good afternoon, everyone. I'm really excited to be here today to talk to you guys about sepsis. Some of our key initiatives that are going out we'll be talking about today, and really the purpose is to spread awareness about sepsis and our program here at North Shore. And these are going to be our objectives for today. So we'll talk about why sepsis care is important. We'll give you some statistics. Let me just amplify myself. Can you hear me better? Is this better? Is this better? Yeah. There you go. I'll hold it. So we'll be talking about why sepsis care is important. We'll give you some statistics about morbidity and mortality on a state level and also here at North Shore. We'll be talking about our different clinical criteria for severe sepsis and septic shock. We'll talk about how to improve our patient care outcomes, some different tools that you have available in Sunrise. We'll go through a case study. Kaz is going to give us a beautiful patient story about one of his own experiences. And then we have some key takeaways and how you guys can get involved with this. So I'm going to start off by giving a quick video from the Sepsis Alliance. And this is a really emotional video. It's only 4 minutes, and I just encourage you guys to be engaged. And it takes you through a couple of patient stories that really shows us the impact that sepsis has on patients and their family members.
My mother, a 20-year breast cancer survivor. She dies of a disease that we never even heard of.
Septic shock, sepsis, and she was like, how do you spell it? I don't know.
Really, does it affect that many people? And why haven't I heard it?
My mother, Mama, she had plans of being a gospel singer. They found a clot in her femoral artery. She got through that surgery, but she started complaining of a lot of weakness, couldn't catch her breath whenever the word sepsis. I didn't understand it.
I remember that I went to bed, woke up to find the EMTs in my room. My doctor friend called the hospital and said, look, unless somebody's coding, there's no one in there as sick as this man is right now. Get a doctor in there. In the next few hours, I had one shutdown after another, all of my organs, lungs, kidneys, eventually a heart attack. My toes were blackened and gangrenous. It was very unclear as to whether I would survive.
It was Halloween. He was up crying. I took his temperature, 102.3, and his color was gray. His lips, everything was gray, and he was not responding. We got to the hospital. He got swelled up, so he was huge. And one of the doctors said, we don't know if you'll be able to take him home. I've been waiting for him for all these months, and I've only had him 3 weeks. He's mine. I wish I would have asked more, but I felt like I was supposed to know as a mother.
I didn't understand that any infection could result in a toxic response that is known as sepsis. It started when I went to the dentist and had some dental work. Following that, I developed an infection. And then septic shock.
I can't even describe to you the horror of seeing her die of sepsis. The body swelling up twice its size, fingers turning black, having to be intubated. It looked like someone took a shotgun and shot her in the leg. That's what it looked like.
For me, this could have a very different ending. And it's why I shared my survivor story.
And the nurse, her name is Annie, and she says, "Are you ready to hold him?" And I said, "Oh my God, yes." She put him in my arms. And she says, "He's gonna be okay." And maybe if I share my story, somebody will learn from it.
Mama's gone, but maybe somebody else can be saved.
So how was that? Emotional, right? So I really love that video because it does encompass all the different outcomes that can happen when you have a patient with sepsis. They can have life-threatening injury, they can have different comorbidities, and you'll learn more about that throughout our presentation. So this is just a quick 3-question trivia, and it's going to test our baseline knowledge of sepsis. So number one says 1 in blank people who die in a hospital had sepsis during their admission. 2, a patient is 4 to 9% more likely to die from sepsis each hour that treatment is delayed. And 3, as many as 60% of septic shock patients can be saved with rapid diagnosis and treatment. So our answers are going to be on the next slide, some of which may or may not surprise you. So number 1 is 1 in 3 people who die in a hospital had sepsis during their admission. So that's pretty significant. Number 2 is true. A patient is 4 to 9% more likely to die from sepsis each hour that we delay their treatment. And 3 is also true that as many as 60% of septic shock patients, their clinical course could have been changed with more timely and effective care. And this is a quote from the NIH that kind of gives you a little broader picture of what kinds of sepsis and what mortality they hold. So SIRS is our early signs of sepsis, holds a mortality rate of about 6 to 7%. And remember, that's increasing each hour that treatment is delayed. Once a patient progresses into septic shock, we're now looking at a 50-50 chance, life or death. In particular, patients who are in septic shock with an abdominal source of infection have an even higher mortality at 72%, and only 30% survive their first year after being discharged. So pretty shocking, and it just goes to show how important this is, and it gives, what I do as a part of this program a lot of meaning, and really goes to show that what's happening at the bedside is key for these patients. And I'm going to be turning over to Ross. He's going to discuss with you guys who looks at sepsis care and why.
It's this one, right? All right, good. Good afternoon, everyone. Thank you for coming. My name is Ross Feynman. I'm one of the senior managers in the quality management department. But before that, I was an ER nurse for a long time, and sepsis is something very near and dear to me. And I think at a hospital like this, it's incredibly difficult to manage septic patients in a facility like this when you see the sickest of the sick patients and they turn to our facility when most other places can't handle them. I think that we have a higher expectation of ourselves and of others when it comes to early sepsis recognition. So Sepsis recognition came about 15 years ago, in 2008, when the Surviving Sepsis campaign began, and almost immediately Northwell started to have an immediate focus on sepsis. Actually, in 2008 is when Michael Dowling challenged us as a system, as a healthcare system, to have effective change on sepsis immediately. So just when the country started to look at sepsis is when Northwell started to as well, and started to take a serious approach to this more than just localized infection. So there's three main parties that look at sepsis very seriously and on very detailed data-driven levels. So within Northwell itself, we have an entire quality management and data collection system called Krasnov, or KQMI, where we collect data. We look at sepsis charts at a system or a hospital rather as large as ours. We look at a minimum of 35 sepsis cases a month, and we analyze them to see how compliant we were with very timely treatment. And when I say timely, I mean fully completing treatment within 6 hours of recognition, which may sound like a long time, but when you look at some of the case studies that we have further down the road, you'll see how easy it is to fall out of those. And these measures are not just to check boxes and to say this is what we did within this time. This is based on many decades of evidence collection, and the guidelines do change as more evidence becomes available on the most effective care when it comes to goals and when it comes to outcomes measures of reducing mortality and reducing hospital length of stay. So within Northwell, we look at both 3 and 6 hour bundle compliance, and we compare ourselves to our peers. And that's one of the benefits of being in a 23 hospital organization, is that we can look at the other facilities and have sort of our own little meta-analysis within our own system. So New York State Department of Health for a long time used to also look at bundle measures as far as what you're achieving within 3 and 6 hours. They then kind of took a step right after COVID to say, we want to start looking at outcomes, not so much just bundle compliance. So they look at some really interesting outcomes, which I'll talk about in the next slides. And the reason those are important is because they're extremely statistically significant. A facility our size throughout the year discharges about 2,400 patients that meet severe sepsis or sepsis criteria, whereas we're only sampling 35 a month. So when we look at the data from the Department of Health, we look at ICU admission, we look at ventilator days, we look at mortality, all with a rather large denominator. So it's very statistically significant. And one of the more interesting facts is that we can also do a peer group comparison. So it's very important that when we look at the way that we care for sepsis patients, we understand how that differs from, let's say, Glen Cove or Syosset. So when we compare ourselves, we look at other academic sites among the entire state. There's obviously hundreds of hospitals within the state. So the data that I'm going to share with you from the Department of Health is mainly compared to other academic institutions of our size. Because realistically, you can't compare apples to oranges when we're taking care of transplant, LVAD, and bone marrow transplant patients. You can't really compare the sepsis care to a smaller community hospital. Their risk adjustment is just much, much different. So Center for Medicaid and Medicare Services, we've all heard of CMS. What they are is a federal organization that sets standard for just about everything we do in the hospital. But they also have to do with both our reputation and how the hospital gets paid and how we keep the lights on. So Center for Medicare and Medicare Services traditionally have looked at the same 3 and 6 hour bundles, but they tie that to our recognition. So everyone has celebrated recently how we're a 5-star hospital, and that partially has to do a small percentage, but a very significant percentage of how we do with sepsis management. Eventually down the line, actually starting in 2024, reimbursement will also be tied to sepsis. So you'll see it in 2026, but it's based on how we do in 2024. So that's obviously very important as well. So moving forward, this is an example of some of our data from KQMI, the stuff that we look at locally. Every month, and actually the meeting's ongoing right now, but we're not presenting because we're here, but every month each hospital in the organization presents their PDSA on what they're doing for sepsis. And it's a great collaborative because we're able to learn from our sister hospitals and understand what works for them and doesn't work for them. Interestingly, most of the smaller sites, I guess I'll talk about it, most of the smaller sites tend to do very well. And that's because they tend to have less complicated patients. They don't necessarily care for the complex patients that we do. But when we look at mortality, that becomes very important. So this is actually an example of the PDSA that we'll be presenting next month at the Sepsis Collaborative. And then on the right-hand side is what some of the sampling looks like. So if you look at, and I wish I had my laser pointer, but I don't. So if you look at the right-hand side on, oh, you tell them to be quiet? Oh, okay. So if you look at the right-hand side here, this is our current compliance with the 3-hour bundle, and you can see how much we've improved just in the past couple of months. And a lot of that has to do with our efforts on the floor, our efforts in the ED, the biweekly rounding and re-education that Jasmine does, not just with the nursing staff, but with also the physicians as well, because this is a full circle of care. It's not just nursing. In fact, a lot of it has to do with providers and kind of changing the dogma of certain types of care, especially when it comes to fluid resuscitation. So Center for Medicaid and Medicare Services data. So don't let this give you a headache. I know looking at this gives me a headache. What it comes down to is Center for Medicaid and Medicare Services compares us to the national average, how well we do compared to other hospitals in the country. And this has to do strictly with bundle compliance, not necessarily with outcomes measures. But when I talk about the state, I will talk more about the actual outcomes measures. So this is our state data. And just to go back to the CMS data, CMS is a very small sample size. I'm talking as little as 8 cases a month, whereas the state looks at thousands and thousands of cases, so very statistically significant. And when we look at mortality, we look at our peer group, so that top line there. Our peer group is other academic institutions. So other hospitals of our size, other hospitals that see excess of 70,000 patients a year, other hospitals that have residency programs, other very large institutions. And when Jasmine said earlier, 1 in 3 patients with severe sepsis or septic shock will not make it out of the hospital, it's true. And it's not just a buzzword statistic. Unfortunately, it's very sadly true. But we do have the power to intervene early and often. So the good news is that our mortality rate actually for this quarter is exactly in line with the median in the state. So we're no better, no worse than the rest of the state for academic institutions. But for the year, for the rolling 12-month average, we're actually about 1% better than the state. And I think when you look at the types of patients that we see, we're the only hospital that I know of that's done a double lung heart transplant recently. I think it's pretty impressive. So the fact that we're better than other hospitals our size as far as actual outcomes that matter, such as mortality, is pretty impressive. So this is sepsis ICU admissions. So the orange line is the state rate. The I guess maroon-ish, no, it's not maroon, baby blue maybe, is the state rate, and then the dark blue lines is us. So for some months we're better than the state, some months we're a little higher than the state, but all in all we tend to be right at, if not a little better than our peer group as well as the state for mortality. Just to reiterate, mortality means expiration during that hospital admission. It doesn't mean that if they are discharged and then they expire at a skilled nursing facility or something like that, it counts as within our facility. So ICU admission rate. So this I actually find very interesting because of how specialized our ICUs are. So you would expect actually them to be much better, much higher rather, meaning our ICU admission rate. So our ICU admission rate is actually fairly low compared to the rest of the state. We're almost, for all the first quarter, we were almost below the rest of the state in ICU admission rates, which is important because I think it actually means that, and everyone probably knows this, we have a very high threshold to get into our ICUs at North Shore. You have to be the sickest of the sick to kind of make it into the ICUs. So what does that mean for the rest of us on the floors and the other units? It means that if that patient's just on that cusp of being extremely sick, they're ours. So the fact that there's a very high threshold to make it to the ICU means that we have to have that heightened awareness of this patient can turn into that ICU patient at just about any moment. And I believe Muse is Dr. Loftus. Thanks.
Great, thank you everybody. Thanks for having me. I'm Dr. Michelle Loftus, one of the hospitalists here, physician advisors, and I work really closely with the quality team on inpatient and ED sepsis cases, reviews, and processes. So Jasmine did a really nice introduction into why we care so much about sepsis, and then Ross helped us understand who else cares about sepsis, and now I'm going to hopefully show you what we here do about it. So the Muse system, which I think most of you are familiar with, or the modified early warning system, is basically a score that helps us detect changes and be able to identify early deterioration, hopefully leading to preventative management, and then as needed transfer to higher level of care. I think this is a good catch-all for some of our sick patients, but I think it's important to know that some patients can be septic without a high Muse score. And why is that? That's because the Muse score is made up of vital signs, which is part of the SIRS criteria, but it's also very heavily weighted on age and BMI. So your 85 and older patients are going to automatically have a high Muse score versus somebody who's maybe in their 20s and 30s, can be septic but still have a very low Muse score because of those separate weights. And then here, just kind of the breakdown of the importance of each metric in determining what the Muse score is. So blood pressure, heart rate, respiratory rate, temperature, altered mental status, and then BMI and age. So sepsis itself. Sepsis, we used to look at sepsis, severe sepsis, septic shock. Now we kind of look at severe sepsis and shock for the bundles, but I think it's still very important to recognize from our standpoint, as we're seeing these patients on the floor, the very initiation of sepsis. So sepsis is a clinical diagnosis. It's an objective diagnosis based on 2 abnormal vital signs. The vital signs are heart rate, temperature, respiratory rate, and also white blood cell count. So if anybody has any infection at all and 2 abnormal vital signs, they're septic. That's it. Even if they are sitting there eating breakfast, look fine, they're septic and should be identified as early as possible before they progress to severe sepsis. Severe sepsis are those 2 abnormal vital signs with the potential source of infection, and then signs of end organ dysfunction. And then going beyond that, you're going to have hypotension and then other downstream effects of lack of perfusion like elevated lactate. So once you have 2 or more abnormal SIRS criteria, which they're up here on the top left. So if you have hypothermia or hyperthermia, heart rate greater than 90, which is not that high. We often see patients with heart rates 90, 93, 94. A respiration rate of 20, or white blood cell count greater than 12 or less than 4. So if you have 2 of those, that's sepsis. If you have end organ dysfunction, then that's severe sepsis. End organ dysfunction can be low blood pressures lower than 90, with MAPS of less than 65. It can be an elevated bilirubin, platelet count less than 100,000, an INR that's elevated, or a lactate that's greater than 2. So these things can be subtle. And septic shock is then when it progresses to a state of low perfusion, which we see with hypotension or elevated lactate. So what do we do? So if you have a patient, the inpatient sepsis screening process is that if a patient has a Muse greater than 4, at least one time during the shift, we're looking at their vital signs and saying, are there any of these 2 abnormal? If any of those 2 are abnormal, then we should be escalating to say, does this patient have new sepsis? And if so, we should start the bundle. The bundles are, as we mentioned, the reason why sepsis can be so deadly is because the most important things have to happen right away: antibiotics and IV fluids. And we have bundle order sets that have all of these things pre-checked so that these things can happen very quickly. So blood cultures drawn prior to antibiotics is very important because it helps us de-escalate antibiotics as needed when our cultures come back. The antibiotics must be given ideally within the first hour that it's identified that the patient's septic. That has the biggest impact, but it has to be within 3 hours, so ideally within 1 hour. Lactate and initial lactate collection, and then beginning of IV fluids until we can assess how stable this patient is. And the ideal resuscitation is 30 mLs per kg, only if they're hypotensive or if they have a lactate greater than 4. And then the repeat lactate in our order set is pre-checked, so that you should expect a call from the lab saying this lactate came back at 2.3. There's an activatable repeat lactate, and that is the lactate that should be drawn immediately. It has to be done within 6 hours. Should not be, we can draw that in the morning after we've done everything else. Has to be within 6 hours. So if the patient has this elevated lactate, starting to become hypotensive, we're going to do fluid resuscitation first. So 30 cc's per kg, unless they have a clinical exception, and they're volume overloaded from dialysis, they have symptomatic heart failure. There's several clinical criteria that can exclude this, but in general, we should remember we should start fluids not at a maintenance rate, but at a bolus rate of 30 cc's per kg. And then if needed, ICU consult, vasopressors. But as Ross said, to get into the ICU, you really have to have gone through all of these steps, failed them in order to get into the ICU. So the earlier we can do these things, the better. And then the repeat volume assessment of tissue perfusion is a repeat lactate, and then some clinical signs on physical exam that show that the patient's resuscitated, their capillary refill, their blood pressure, and their lung status, multiple different things like that. So we do have some tools to help us with this process that Jasmine's going to go over. Or Ross, sorry.
I'm not Jasmine, sorry to disappoint. So, a lot of what Dr. Loftus was describing is really a lot to remember. And unfortunately, having reviewed sepsis for several years, I see this in my sleep and it's very disturbing. But I think that, it's important to note that we have some really great tools in place to help you remember all the steps required for sepsis care. But what I'm asking of you is to understand the early recognition and act on that recognition. So like Dr. Loftus said, there is an expectation that all nurses are screening their patients that have a MUSE greater than 4, so not every single patient, that have a MUSE greater than 4 once a shift for sepsis. And if that patient is positive, in your clinical opinion, you are to call the provider, whether it's the ACP resident, whoever it might be covering that patient, and say this patient screened positive. So the thing about MUSE is, of course, there are other things that can elevate your MUSE, whether it's a patient who has seizure activity, a patient who's withdrawing, a patient who's in pain for other reasons, and that's why their heart rate's high. So you have to use your critical thinking and your clinical decision making to determine, is there any chance this patient could have an infection that's driving their MUSE to be greater than 4. So the MUSE, by nature, modified early warning system, is to give you that early warning to kind of that indicator of badness that's coming down the line. It's kind of like your spidey sense for patient care. So there is a screening for sepsis tool in the vital sign flow sheet. There is the MUSE score, which I mentioned. It is on the header of every single unit, on every single patient in the hospital. Within the ED, I know my ED team knows very well, there is an ED inpatient order set for the providers and the sepsis provider contact note. So that was something that we fought extremely hard at the system level, and that originated here at North Shore. It was ours, and by us, I mean Dr. Loftus's idea, to have a specified provider contact note for sepsis for patients that screen positive for sepsis, to differentiate from like your run-of-the-mill provider contact notes where the blood cultures came back positive, or the patient's in pain and needs breakthrough medications, whatever it might be. This one is specific, and I'll go into why it's important and why it's very useful. Whoops. Okay, so the inpatient sepsis screening tool, this should all look familiar. It exists in your vital sign flow sheet. It is simply a Q shift. Yes, I screen the patient for sepsis, or no. If the MUSE was greater than 4 and the patient has no indicators of sepsis, then you would still say yes, but you can write a comment, patient does not meet sepsis criteria. If it is yes, then you're expected to do the next thing, which is where you would normally search for the provider contact note in the same exact screen where it says provider. It's the very last one, provider contact note. And what's really cool about this, and if anyone knows how difficult it is to get something changed in Sunrise, you'll understand how big of a success this was to get this put in. This pulls in that data already, so you can click exactly why you think the patient meets sepsis criteria, and then once you generate the note, it'll pull in other things like the vitals, the most recent MUSE. I forget what else it pulls in, but it brings in the data that's going to help you with your SBAR to hand off to the provider. And then all of the providers, we meet with the residents, we meet with the ACPs, we meet with the attendings, we meet with the intensive care staff. All the providers are aware that they're going to be receiving a call from you, that you believe in your clinical decision making that this patient has screened positive for sepsis, and they are expected to launch the sepsis order set. So the great thing about the sepsis order set is that it takes care of all the things that you have to remember. It gives you the option to give that 30 cc per kilogram bolus. It gives you the option to select antibiotics. It gives you the option to draw that lactate and then have the automatic reflex lactate if it's greater than 2. But as Dr. Loftus said, it's extremely important that we're timely with this administration, timely with recognition, and timely with antibiotic administration and checking of the lactate. Previously, I've been to other meetings such as PCS, collaborative care, and I kind of made the statement of, you wouldn't wait the next morning to call a code stroke, right? So you wouldn't, if your patient's having stroke symptoms, you call a code stroke immediately. So we need to shift our thinking of sepsis to that of a code sepsis, which is kind of the standard of care in most places, not necessarily something that we need to call overhead, but we need to act on it appropriately. Because in all honesty, by the time it gets to a rapid response or the patient is a rapid response, their mortality rate is extremely high. If they're already hypotensive and they're bordering on septic shock, they have nearly a 50% mortality rate. And there's nothing in the hospital that has that high of a mortality rate. So I think it's something that we need to take extremely seriously, but everyone in this room are the ones that have the power to recognize early and really make the difference in the patient's outcome. So here we have a case study where there were a lot of opportunities to take away, and it's a really good one that we kind of stumbled on. So this is a real patient. We removed any PHI, of course. So this is a 69 gentleman who came in with known liver disease. Wasn't really sure what his liver disease was. Came with intermittent chest pain, bloating, and hiccups for a few months. So nothing really mind-blowing. The chest pain was all over. It was sharp and worse with food, and he's not really sure what makes it better or worse. The pain stays in the chest area. He denies any shortness of breath, jaw pain, arm pain, no history of heart disease. The hiccups occur at random. Most recently, he felt bloated. So when he was at Jamaica Hospital last month, he came in for some blood work, and he's not really sure what it was, but thinks it was gastritis. Of note, he has been a daily drinker for many years, but cannot quantify but more than 20 years. But he quit alcohol 8 months ago. So a lot of things on the differential, right? Could be issues with gastritis, could be issues with hepatitis or liver disease, a lot of things. So this is the H&P. The patient was worked up for chest pain. There was no EKG changes, did have normal troponins. The findings in the ED was the ultrasound showed choledocholithiasis, and the plan was to get an MRCP and follow up with the hepatology fellow. As well as cirrhosis. So kind of pretty much your run-of-the-mill patient here at North Shore, nothing out of the ordinary. So a couple days into the stay, the patient starts to have just mild signs of kind of something is going on. And the thing with sepsis is that it'll always give you warning signs. It wants to kind of creep its ugly head out and show you that I'm here and I'm coming. So patient had some early warning signs here. At this point, the Muse was going up, obviously. There was an order for blood cultures due to the choledocholithiasis to rule out an infectious cause. So blood cultures were drawn appropriately. Obviously, we have to make sure that we date and time them accurately, get as much blood in there, at least 10 cc's, that's standard. So blood cultures were drawn on the 25th at 12:23, and the indication were a quote-unquote infectious workup. So what we see here is that we're already starting to have some early signs. Not thrilled with the blood pressure. It's soft. I think if we go back, no, we don't have a blood pressure earlier, but this was soft compared to what the patient came in. So that was the 25th. Now we're on the 26th. So we're already at least well over 24 hours into the first warning signs of sepsis. And if there are warning signs of the body's systemic inflammatory system is already starting to kick into action, that infection's there. It's already there. So the next day at around noon, heart rate continues to go up, and then we see a big jump from around noon to 1440. Patient spikes a fever, heart rate goes into the 130s, pressure drops. So now this patient meets full-blown sepsis criteria. This, I mean, in my opinion, you probably would have had enough earlier to kind of call for a code sepsis, but this is Monday morning quarterbacking, of course, knowing what the outcome was. But at a minimum here, you have now a fever, you have tachycardia, and your blood pressure is already starting to drop. So patient's starting to decompensate. Zosyn was ordered the 26th at 16:45, given at 16:59. So very timely administration of antibiotics. So aside from the answers that are in front of you, just from the audience, understanding what we've talking about bundle care of sepsis rather than quote unquote piecemealing things together for sepsis. What are kind of our opportunities that we see in this case already from the treatment that we know occurred? Anyone?
Provider note.
Provider contact note, sure. So that's really, who said that? Thank you. So that's a really good point. So had there been a provider contact note of which the script is to launch the sepsis order set, all of your bundles would have been achieved. We wouldn't be piecemealing things together, and we wouldn't have to remember all the things that Dr. Loftus mentioned on the criteria. So here we're kind of piecemealing things together. We drew the blood cultures yesterday. We're now just giving antibiotics, but we're not giving fluids to this patient with a very questionable blood pressure. And rightfully so, it's very hard to remember all those things. That's why we have order sets. So blood cultures were already drawn 24 hours earlier. They're not back yet. So as we mentioned, the opportunities here were to start the sepsis bundle on time, initiate inpatient sepsis order set, and escalate vitals to a provider immediately, and prompt sepsis as a differential diagnosis. So this was around, like I said, afternoon into evening of the 26th. So now we're at 2023 on the 26th. This is the actual rapid response record. So rapid response note from the medicine PA, RRT called because of hypotension, blood pressure is now in the 50s. The patient was assisted at the bedside, not in any distress. Of note, the patient spiked a fever for the first time earlier today. So this is something we knew about. We knew about this earlier on the day. And, you know, to be honest, and we look back at things, and this is how we learn from things, we didn't act in a complete and cohesive manner. So now, from what we know about sepsis, this patient is in a distributive shock, right? This patient's vasodilated. They have leaky capillaries. So blood pressure is, it's hard to see, but this one's 59/31. Heart rate's 116. During the rapid, we gave 2 500 cc boluses, which is great, giving fluids, not quite the 30 cc's that we want. But in these circumstances, if the provider indicates that they want to give less than 30 cc's, that's fine. The patient has heart failure, kidney disease, whatever it is, that's fine as long as it's documented. So now we're at the next day, midnight 30, so 12:30. Patient's pressure is not responding. Was given periodic boluses. The initial rapid response ended with the patient remaining on the unit at 2100 on the 26th. So it's no surprise the patient rebounded, had refractory shock. So hypotension after fluids, by definition, is septic shock. So you give fluids, they maybe improve, they don't improve, and then they become hypotensive again after fluids. That is the textbook definition of septic shock. That means the patient does not have any compensatory mechanisms left, and that in and of itself is what carries a 50% mortality rate. So patient goes to this, gets admitted to SICU, which makes sense. It was a surgical pathology. It was the choledocholithiasis causing a gut bacteria sepsis. So the patient, like I said, was transferred to SICU on 2/27, about 48 hours later from the initial suspicion. So we knew about this, right? We knew about this about 2 days earlier. The patient was put on a vasopressor and sent to the SICU, as I mentioned. So interesting thing here, what we discovered in one of the critical value notes is that, remember, we drew those cultures on the 25th. On the 27th, they came back positive, and the response was to give 500 cc's of fluid. When we're at the point of drawing cultures and giving IV antibiotics for suspected systemic infection, we need to be giving fluids, especially if there's a question of the patient's blood pressure. This was done 2 days later. So what are our takeaways? The takeaways are obviously early management, early recognition of sepsis, have an extremely low threshold to escalate to the provider. We will back you 110%. Dr. Loftus will call and yell at any providers who don't take the call seriously, but that's what we do as nurses, right? We advocate, and we should never be scared to do so. Arguably, these are the sickest patients in the hospital, and we have a responsibility to care for them as so. So if there's anything you take away from these, it's that any signs of scariness or badness with a MUSE greater than 4, or even not a MUSE greater than 4, please escalate. Don't be scared to do so, and you're supported 100%. Thank you.
Hi, everybody. My name is Konstantinos. I go by Kaz. A lot of people know me that way. I'm coming to share a story that I myself experienced as my time on telemetry. A little bit of background. I've been a sepsis champion for maybe a year and a half. I was approached by my manager while I was on 2DSU. To represent the unit as a sepsis champion. I thought, okay, why not? I get some clinical ladder points, some good experience, it'll look good on a resume. Eventually, I started attending the meetings, and I kind of realized that I kind of enjoyed the subject. I thought I was learning a lot. It helped me educate other nurses on my floor, especially a lot of newer ones. I told them about the bundles. I told them about the screening tool, the provider contact notes, and what to look for when screening your patients for sepsis. By no means am I an expert, not compared to any of these people over here, but I do my best. So this is my story. Let's see, does it work? No, this is this way. Okay. So funny enough, when I reviewed the case study, when I was about to put my information down, it's actually pretty similar, and it's not that similar, but you can see it's another GI case actually. So I'm going to give you some background on the patient history. So it's an 88-year-old female. You can see that she has a significant cardiac history there, and a recent admission for cholangitis secondary to colloidal cholelithiasis. She was admitted a couple months before she came in. Her case ended with a cholecystectomy, and she came back complaining of the same abdominal pain that she had for her recent admission. So the ED took her vital signs. They did an EKG. You can see that she had a heart rate of 120 beats per minute. She was sinus tachycardia at the time, and she had a low-grade fever, rectal temperature of 100.4. So they drew some blood cultures. They came back positive for Morganella morgani, and she also had a UTI. UA was positive for E. coli. And she also has a positive lactate of 3.3. They also ran a CT abdomen and pelvis, showed that she had, compared to her old CT abdomen and pelvis, she had a new mild to moderate right interhepatic biliary duct dilation. So she was admitted to telemetry with the admitting diagnosis of cholangitis again. So they gave her a liter of fluid in the ED and also IV Tylenol for her temperatures, and also started her on Zosyn with the theory that the Zosyn would take care of the E. coli and the blood cultures at the same time. So GI was also consulted, and an ERCP was ordered. So the ERCP ended in her having her common bile duct stented. From what I understand, the notes said they weren't really able to stent the right side, which is what they wanted to do because of angulation, I think. But they stented the common bile duct in hopes that they could get rid of whatever it might be blocking the infection. So that's a little bit of a story for her. So this is my experience with her. I first came upon her. She was ANO4. All vital signs were normal. White blood cells were still a little elevated, but she was not complaining of any symptoms, any pain. Very pleasant. We got along very well. I gave her medications. I cleaned her up. I took care of her between, let's say, 7 o'clock and 11 o'clock. Around 11 o'clock, I got a notification from the monitor technician. Told me that she had converted from sinus rhythm to rapid AFib between the 140s, 150s. So first thing I thought was rapid AFib, we got to fix that. So I notified the provider. At the time, the BP was 97/58. She was complaining of shortness of breath, but I attributed that to the high heart rate. The ACP ordered 5 milligrams of IV low pressor. So we gave it some time to see if it would work. It did not. No, there was no change in the heart rhythm. There was no change in the rhythm or rate. I was continuously checking her blood pressures until I found that her electronic BP was around the 80s. So I did a manual blood pressure, got 78/50, and she was still complaining of palpitations. Around that time, I notify the provider again, and she, with me, agrees to maybe call a rapid response to see if we can do anything better for this patient. So we call a rapid response to the patient for tachycardia and hypotension. At the time, we were more focused on the cardiac side of things. I was on a cardiac floor. So you can see more cardiac medications were ordered. You can see the low pressor, you can see the amiodarone. Patient was dig-loaded, sorry, but still nothing. No change in the heart rate, no change in rhythm. So we weren't sure exactly what to do. At that point, the ACP considered this, well, could this be sepsis? So when she brought up the question, the patient started complaining that she started feeling cold. So the ACP says, well, okay, why don't we check a rectal temperature? So they take a rectal temperature. We find that she has another low-grade fever of 100.8. CBC was ordered again, another lactate was ordered, and we also ordered repeat blood cultures. On top of that, we gave a 500 cc bolus. As Ross mentioned before, you have a significant cardiac history. It's not easy to just give as much fluid as you need. So the 500 cc bolus was given. The rapid was ended, and the patient remained on the unit. A couple hours later, the patient's lactate returned. It was a 3.3. WC was normal actually, but the patient's heart rate still remained 140 to 150. It was still AFib. The BP was a little better. It was between 85 to 90 systolic. So the ACP was giving me more boluses to give to this patient because of the hypotension and obviously the lactate. You want to bring that down. Patient was asymptomatic at the time. I think she was actually starting to lose her patience with me because she wanted to go to sleep. It was late at night. So I still didn't feel good about the situation. I had given maybe about 1.5 liters of fluids at this point, and nothing was changing. Continuously doing blood pressure, still low 80s, still low 90s, back and forth. At some point, because I had spent so much time with the patient, I realized the things she was saying just wasn't making sense anymore. I did a mental assessment on her. It seemed like she wasn't oriented to place or situation anymore. Really concerning. Heart rate was still the same. Blood pressure was the same. I actually did another manual on her and got 75/49. The situation was becoming worse. I spoke to the ACP about it. And again, we agreed, let's call another rapid response. This must have been maybe around 3 o'clock in the morning. So the second RRT was called. Same team came back, this time for AMS, tachycardia, and hypotension again. Mickey was consulted, and as Ross said before, it's very difficult to get your patient to go to the ICU. The patient was not a candidate, so they had to remain on the floor. The team wanted to do a CT head to see if there's anything going on up there, and additional labs were ordered. But at this point, the patient was AMS, completely uncooperative. She wouldn't let us do anything. She wouldn't let us draw any bloods. She barely allowed us to do any vital signs. It was then that the administrator that was present during the rapid response thought, well, maybe a family member can help convince her to see if she can take one of these tests and agree to the labs, agree to treatment. The son was called. He spoke to the patient, and the patient finally agreed that if he was present, she would be willing to go through the tests, go through the treatment, and do what has to be done. Because at that point, she didn't even believe she was in the hospital anymore. So we waited about maybe 45 minutes, and the son finally came back to the unit. He sat with her, she took her medications, the labs were drawn, and she agreed to the CT head. Tachycardia was still persistent. She was hypotensive, but a little better than before. Again, upper 80s, lower 90s, still AMS. They decided to keep her on the 1-to-1 for safety. So PCA sat on the 1-to-1 just to make sure she didn't get out of bed, fall. She was 88 years old, and septic at that point. That was the end of my shift. Luckily, I was fortunate enough to be able to order the chart and see what happened after. So the day after, because the multiple RRTs were called for the tachycardia, AMS, hypotension, the low-grade fever, ID was consulted. They diagnosed her with sepsis, and they asked for another, so they asked for a GI consult again. GI ordered another CT abdomen and pelvis and showed that the right duct dilation was persistent. Another ERCP was ordered, okay, and then the patient was taken, and the previous stent that was placed in a common bile duct was actually removed, and they were able to stent the right side. They removed another stone out, and they were able to stent the right side and drain. It didn't say how much, but they drained about brown, cloudy bile from her liver. Between that time, she was kept on a cardizem drip. She remained getting her Zosyn. She got the midodrine just to keep her blood pressure up a little bit. And I saw that after the procedure, after the stenting of the right side, you could see everything downtrended back to baseline. The patient remained AMS for a couple days. She was still uncooperative here and there, but you can see that she was returning to her normal after a while. After a week, the patient was deemed stable. They discharged her back home with PO flagyl, and it was a good scenario. I mean, to me, that night was it was very stressful, but I felt good at the end of the night because I know that I helped someone, and I felt even better reading this because there was just some type of a feeling of victory when you see the last ID note say sepsis resolved, you know. It's this is a quote by me, apparently. So my lesson learned speaks for itself. No single discipline can handle this problem. No. I want to go, actually, I don't have to go back. I want to point out some things. So it was the monitor tech that showed me that she converted, okay? It was the ACP that decided to look into sepsis and get a rectal temperature, okay? It was the administrator that convinced the patient to get, to convince a family member to speak to the patient and get the treatment done. It was ID's contribution to get GI involved again and get another ERCP done, you know? And the early recognition was really key to everything, along with the interdisciplinary collaboration. So I hope. That's my story.
So that was a really beautiful story about a real life patient and something that happened in our institution. And, you know, Kaz has moved on to the PACU, but this is a story that will stay with him and affect his nursing practice. So I hope that everybody was touched by that. And he made some really good key points that nobody can do this on our own, and there is no single test that detects sepsis. But if we know the criteria and we're well versed and we feel empowered to escalate those signs and symptoms, we can save a lot of patients' lives. So thank you, Kaz, for your brave story and for saving a life. So let's give him another round of applause. So in general, we'll just summarize some key takeaways from our presentation today. And first and foremost, we want you guys to remember and continue to educate our colleagues here that the progression from SIRS to septic shock holds a tremendous mortality, about 50-50. So our early recognition, early intervention, aggressive treatment is key. Next, anybody with a Muse score of 4 or greater and a known source of infection, please, please, please launch your provider contact note for sepsis and escalate that immediately. Next, there is no lab test that can detect sepsis, so therefore it is a clinical diagnosis, and we have to rely on our ability to recognize the constellation of symptoms and prompt that treatment. Any team member can question the presence of sepsis. It can be ADN, PCA, anybody that has that question looming in the back of their mind, always feel empowered to bring it to a clinical staff member and say, do we think this patient is septic? And please utilize your Sunrise tools. Look at your Muse on the header. Do your screening for sepsis every shift for Muse with greater than 4 and use your provider notes. And I think this last one is very important for our nurses. I was an ED nurse for a long time, and you know, when you have a lot of medications and a lot of patients, a lot of our times our antibiotics, we don't see it as TPA or vasopressors. We're like, okay, we have meds at 12 o'clock, 11 o'clock. antibiotics are ordered, and we'll go ahead and give that an hour later. But that is the key of treating our sepsis patients and bringing down that mortality and saving a life. So when we see those stat antibiotics and those fluids, we want to get it up as soon as possible. And then finally, to make this actionable, how can you guys get involved? You can join our team and become a sepsis champion. So you'll see Kaz, myself, Ross, and some of the team there with Flo. And what happens when you are a sepsis champion? So we meet once a month in a hybrid platform. Our next meeting is on October 11th. We'll be in Kaufman Boardroom once a month. And there we talk about different situations. We may have patient stories similar like to the ones you heard today. We keep you guys up to date with the latest CMS guidelines and sepsis treatment. And we ask that you assist us in spreading the message and bringing the education back to your units. And you also have the ability to earn clinical ladder points. So please sign up. If anybody's interested, we'll leave the QR code up for a little bit. And you can reach out to myself, Flo, Dr. Loftus, Ross, or our star champion, Constantinos, anytime. And we really thank you guys for your engagement today. And we look forward to seeing maybe some of you on our sepsis team. So we'll have the next couple of minutes just for questions. If anybody has any questions of maybe how to get involved or things they might see on the unit that need clarification, we'll open the forum now. All right, I'm gonna test you guys. Oh, Andrew, you have a hand.
So not a question, but first of all, thank you guys so much for putting this on. I think that was amazing, and thank you for sharing that story. I think it's a reflection of how sepsis really can be something that we don't see when we're kind of looking at everything at the same time, right? I think that one of the things that is especially is really powerful, and the real message that I got from today was that if you are feeling that spidey sense, you have that gestalt where you feel like something's just not right to escalate, right? Especially when you think about those different types of things, like when you first started seeing, hey, all of a sudden they have a change in a rhythm, and they have a tachycardia. Why is that? Always questioning why. I see a lot of nurses doing something different, a lot of nurses in the room, and to always think about that. So thank you guys so much for sharing. That was really great.
Go ahead.
Nadia.
Nadia.
So what I see sometimes is that in surgical patients, some of the order sets may be Tylenol Q6 hours. So the patient may be getting standing Tylenol. So a lot of times people are looking for the temperature to change. These patients may not come in with an active infection. They're looking for a temperature to change, but once the temperature changes, they may just see a symptom, heart rate increase, something like that. So you have to be mindful also, like looking back into the orders, are there any antipyretics? Is there anything else that could be masking what I'm actually seeing? And sometimes you don't necessarily have a source of infection. It could be just a process, or they develop an infection while they're there.
Yeah, Nadia makes a good point. Similar to when you have patients that may be bleeding and they're on a beta blocker, you're not going to see that heart rate elevate. So if you're on antipyretics around the clock for pain, you might not see that temperature go up. So always important to look at our lactate levels, look at our white counts. Our respiratory rates are very important. And I know if anybody in this room has enough experience with sepsis patients, you kind of see their color and things start to change. So if that's ever looming in the back of your mind, absolutely keep that sepsis question. More than 60% here, so it's living in a lot of our patients.
Along that line, I want to say, if you ever want to look like you're guaranteed within the next year, if you notice a new high heart rate, but you say they don't have a fever, check a rectal temp, and then you see that's elevated, you're like, wow, you diagnose sepsis. It's one of the most common things you see is a slowly uptrending heart rate, but no fever. Check a rectal temp, and you'll be right. I guarantee if you do that once this year, you'll be like, wow, you found sepsis.
Right, and the rectal temperature is a really good measure to get a core temperature. Sometimes, we'll have a normal oral temperature, but you might have a rectal temperature of 103. So always be inclined to ask for that ordered as well.
And I think also it's important that as a nurse and as any sort of provider, you're confident that you
is that you're aware of your unconscious bias towards your patient, right? So on a neuro floor, obviously everything is neuro until proven otherwise, right? On the ortho floor, ortho, on the cardiac floor, that increase in heart rate was treated as tachycardia, not as the sign of the other underlying disease process. So when we're aware and we're conscious of our unconscious bias, which I guess then we're thinking the conscious bias, but when we're aware of the shutters and the blindness that we have for our patients, you'll be that much better of a diagnostician, that much better of a nurse, because you're kind of conscious of the fact that, hold on, I know that I thought that this might be an increase in heart rate due to their underlying AFib, due to, you know, their changing in cardiac dose or whatever it might be, but always think.
What triggered
Right.
that? What triggered?
Listen, you know, converting from sinus to AFib doesn't have a 50% mortality rate, right? The septic shock does. So there's no harm in just you know, escalating and getting that rectal tap, or, you know, drawing that EEG, drawing those holes, or starting those fluids. There's very little harm compared to the alternatives. So I think if you're just aware of that, your thought process initially might be something else other than sepsis, just, I don't know, make sense. So that's there.
Diane?
I think to add to that is another bias that I find common and we kind of saw that on the video, how many different age groups and different types of infections cause sepsis. The guy went for a dental workup, you know, he was what, 35, 40 years old, and you tend to write off those symptoms because you're like, okay, this is a healthy 30-year-old, this is a healthy 20-year-old. But they can still be candidates for sepsis, and I think not writing that bias off again is really important as well.
Thanks, Diane. And also brings to another good point that the stress on sepsis really did come to the forefront because of pediatric patients. So age, it's not just our elderly, and I know we don't see many peds here unless you work down in the emergency room, but anybody can have sepsis, and that video was a great way to tie this together. It's Faces of Sepsis, it's called, because there is no face, there is no race. And you may see signs in the cafeteria that we've put up as well, and it shows all the faces of sepsis, all different ethnicities, all different demographics and age groups, so very important. All right, who can tell me the mortality rate of septic shock? I'll give you a hint. It starts with a 5. 50%. All right, and if nobody, any other questions in the crowd? Anything on Teams? All right, thank you guys for your patience. Thanks for listening.